it's such a pleasure to be with you all. I'm excited to talk about this subject. And, I just want to acknowledge it's been a hard couple of years with COVID-19 for everyone, but especially for, folks who are in residency and medical school. So, I just want to acknowledge that. That's tremendous work you all have been doing. I think it's helpful to think about COVID-19 in the context of emerging pathogens. So I want to talk about that a little bit. No financial disclosures to talk about. Here's an outline for the talk. I'm going to describe some recent emerging pathogens, including some of the vector-borne pathogens that we've seen in the last 20 years. I'll discuss some more traditional travel medicine topics, including vaccine-preventable illnesses, malaria, skin lesions in return travelers, and just a few comments on travelers area. So I was a resident here at Sinai. I was here from 2000 to 2003 in residency, and then 2004 and 2005 I did fellowship in ID. So, when I was a second-year resident, we had our first encounter with a novel coronavirus, and that was the SARS 2002-2003 outbreak, which started in southern China, moved on to Hong Kong, and then rapidly spread to multiple continents. It was an era before we had, really the level of information sharing that we now have, and sequencing power and mRNA vaccines. So, the response this time has been very different, but, a few general themes was the idea that, we were seeing zoonotic infections that were making jumps from animal species into humans, and they were finding ways to spread from one human to the next. There's several pathogens on this list that'll be related to bats. The coronaviruses tend to have some diversity among bat species that is important in their transmission among humans. Around 2003, we had a novel avian influenza, H5N1, mainly spreading among poultry and wild birds, but in some cases crossing over to human species. That's been in the news a little bit more recently, again, among poultry, but every once in a while, there's a person that gets in close contact that can get an avian version of influenza. And then 2009, we had a novel influenza strain among humans. That was the last pandemic that we really dealt with. So if you think about influenza viruses, every year they go through some genetic drift that causes seasonal variation in their antigens enough that we need to change our vaccine every year. And then every 80 to 100 years, they go through a genetic reassortment event in which they're getting pieces of genetic information from birds or swine, or pigs in the case of 2009, and recombining with human virus genetic information to get a new virus. So that's what we had in 2009 was an H1N1 influenza, a genetic shift event that led to a pandemic. Fortunately, it was a relatively mild version of influenza compared to the 1918 influenza, but nonetheless, it caused a lot of disruption. It started in April of that year, and now what we call seasonal influenza is mainly H1N1. The next coronavirus we've dealt with was in the Middle East in MERS 2012. Again, we think probably making a jump from bats to possibly camels, but then to humans, another severe respiratory syndrome. In West Africa in 2013, we had an Ebola outbreak that was very, very much larger than any that had previously been recorded in terms of numbers as well as number of countries involved. We then saw several vector-borne illnesses, chikungunya, Zika, and yellow fever, that were really emerging in new parts of the world. So chikungunya was really described mainly in parts of Africa for many decades. And then later we would see some cases in Southeast Asia. But then, in Southern Europe, they started seeing some cases. This is a virus transmitted by mainly Aedes aegypti. But that mosquito is close cousins with another one called Aedes albopictus that's seen in other parts of the world as well. So once chikungunya arrived in the Americas, in the Caribbean and Central and South America, we saw a very rapid spread because there was not really any local immunity among the local population. So, and these mosquitoes are very prevalent. There's a lot of exposure. So we saw a very large outbreak of chikungunya. Similarly, when Zika arrived in the Americas, it really had not been described in Brazil before 2015. Then we saw a large outbreak that was also associated with microcephaly, congenital abnormalities. We learned that it could be also transmitted sexually. So, a really pathogen that had really had its origins in Africa and later parts of Southeast and Asia and parts of the Polynesian Islands. We saw this huge outbreak in the Americas and including here in the United States. Fever Brazil in 2016 is worth thinking about just because most of yellow fever virus cases are mainly in the Amazon basin of Manaus, the parts of Brazil far away from the coast. But in 2016, we started seeing more cases in large cities like Rio and Sao Paulo. There was another Ebola outbreak in 2018 in the Democratic Republic of Congo that was significant. Also because of the fact that there was so much political instability, it was very difficult to get healthcare workers safely deployed there. So it made the control of that outbreak a lot more challenging. Nipah virus in India, some of you may have heard about. I think most of us have probably seen the movie Contagion by now. But if you think about the movie Contagion with Gwyneth Paltrow, it's kind of this virus that's transmitted among bats and pigs, and then it makes the jump to humans and then becomes very infectious and causes encephalitis. So that was one that was based on this Nipah virus that really, fortunately is not readily transmitted among humans, but it is associated with exposure to pigs and bats. And then we read the COVID-19, which is really another zoonotic infection where we see a lot of bat coronaviruses in southern China, going through lots of mutations and eventually making a jump over to human species. Okay, so that's the last 20 years have really been remarkable for the number of emerging and re-emerging pathogens. I wanted to talk today a little bit about how we prepare travelers and how we evaluate them when they come back. So the pre-travel evaluation, a lot of you are doing this in your clinic. You're getting patients who may be immunocompromised. So you're trying to assess, have they had a kidney transplant? Are they on Humira for ulcerative colitis? So we have to think about their immunocompromised before we use some of these vaccines, which some of which are live attenuated vaccines. You think about where they're going specifically. So for example, within Peru, some people make a journey just to the highlands in Cusco and Machu Picchu, but others are going to go up to the north where the Amazon basin of the jungle has more problems with yellow fever and malaria, for example. They're coming into our office for travel vaccinations like yellow fever. So I'll talk a bit about those. We spent a fair amount of time about insect precautions and how to prevent insect bites since they transmit so many of these illnesses. We talk about antimalarial prophylaxis and food and water safety, as well as management of travelers' diarrhea, many times with antimotility agents and as well as antibiotics. And then general safety, because there's a lot of infections that you can get abroad, but your overall risk of acquiring these is actually much lower than having a problem with a car accident or something like that. So it's good to remind people, not to drive on roads they're not familiar with, use seatbelts, avoid renting mopeds, etc. Okay, here's a list of travel medicine vaccines that we talk about. On this column, I'm putting some of the more exotic ones. On this side, some of the more routine ones that everybody gets regardless of travel. The red ones are the ones that are live attenuated vaccines. So yellow fever is an important one in that it's required for entry into many countries. It's a virus transmitted by Aedes aegypti mosquitoes. And the vaccine is now valid for life. We used to give 10-year boosters, but now we know that there's good long-term immunity from a single dose. There are many people who should not get a vaccine against yellow fever. So immunocompromised from kidney transplant, long-term use of steroids, long-term use of TNF inhibitors are really categories for avoiding the vaccine. It's to be avoided in pregnancy. We can give it to children above 9 months. But we have ways of writing exemption letters. So people that are going into a country where they may have it as a requirement, even if they're at low risk, can get an exemption letter, and we have a part of the card to write exemptions. Typhoid vaccine is the one that we use the most in its injectable form. There is an oral typhoid vaccine. Right now it's on back order. It's a live oral vaccine. It's an inactivated injectable, so it's a little bit simpler. You'll hear about rabies vaccination from many parts of the world where there are dogs, cats, monkeys, raccoons that are not vaccinated for rabies. And some travelers go into really remote parts of the world where they may not be able to get access to post-exposure prophylaxis. So we do sometimes recommend pre-travel rabies vaccination, although it's relatively expensive and insurance is like hit or miss on whether it will cover it. So that's sometimes a limiting factor. Aedes encephalitis is another virus transmitted in parts of the world where Aedes aegypti is prevalent, but it's mainly found in parts of Southeast Asia, parts of India and Bangladesh. So if you have a traveler who's going to rural Southeast Asia, let's say Cambodia and Thailand, and it's a relatively short trip, just a week or two, you might just opt for insect prevention measures. But if they're going to spend a couple of months, biking around the jungles, then that's another scenario where you would want to consider the vaccine, two-dose vaccine series. So cholera is a live attenuated bacterial vaccine. We don't use it much. It's an oral vaccine that's available mainly for, I would say, refugee camp workers, people that are going to do work where there's a cholera outbreak. For most people, just avoidance of contaminated water is the way to go. It's not such an effective vaccine, so there's not a lot of appeal to it. And then on this side, just more routine vaccines that we often catch up with when people are traveling. Young people tend to have immunity already to Hep A and B from their childhood vaccinations, but for adults, we're often playing catch up on those. There are certain parts of Africa, for example, where there's a higher rate of meningococcal meningitis. So we're doing boosters for some people who may be at higher risk for those. And then, some of the more routine childhood vaccines we'd like to know people are already up to date with. Okay, so then when people come back from travel, we're often asked to think about very exotic possibilities. So, it's good to keep that list in mind, but you also want to have a list of possibilities that are more routine, mundane, local in terms of causes of fever. So yes, definitely be thinking malaria, dengue, chikungunya, but you also want to be thinking about influenza, urinary tract infections, other things that are, kind of more local here as well. So here's a case example just to, get us thinking about this. This is a malaria management case. This is a 45-year-old UN employee who returns from a 6-week visit to his home country of Nigeria with fevers, diarrhea, headaches, dark urine, renal failure, severe anemia, and icterus. So here you can see the icterus, and if we look at his bilirubin, it's going to be elevated. Most of that's going to be indirect. Again, this is a hemolysis problem as opposed to a direct liver injury problem. And the hemolysis is going to be happening because there are these intracellular rings. Okay, so here are the parasites of malaria. If you get this on a board exam, you're probably going to see, some rings inside of cells. You might see more than one ring in a single cell. The predominant morphology we're seeing here are the ring forms. We're not really seeing any of the gametocytes in this particular smear or the schizons. So those are features that I'm going to show you in another slide, to help distinguish other species. But we also know that this patient has a severe case of malaria. So there is some renal failure. He's got a high parasitemia and severe anemia. So most likely this would be a Plasmodium falciparum case because that's the type of malaria that tends to cause the worst type of malaria. So treating falciparum, I'm going to get into in a second when we talk about complicated versus uncomplicated malaria. This would fall under the category of more complicated malaria because we're having end organ damage of renal failure. Okay, so Plasmodium falciparum, if you get it on a board exam, I was mentioning, they're probably just going to show you the rings. They may show you a banana-shaped gametocyte. That's kind of a classic finding for falciparum. Now, remember, with malaria species, we don't really have a cultural system to grow them in artificial media. We are getting more access to rapid antigen testing and PCR, but I would say the main classic modality is just microscopy, looking at a thin or a thick smear. And this is what we're looking for. We're looking inside the red cells for these rings and sometimes a gametocyte. Also worth noting that your automated cell counters that give you your CBC and tell you the platelet count and the hemoglobin and the hematocrit and the white cell count, those are not very good at looking inside of cells. So if you're thinking about malaria, you need to make a diagnosis by requesting the specific peripheral blood smear for manual examination by a microscopist. Okay. Compare that falciparum case to the second case. This is from a person who was working with Doctors Without Borders, 35-year-old woman physician who worked with MSF in the Democratic Republic of Congo for about 11 months. She reported having 3 bouts of malaria while she was there. And each time she was treated with artesunates, which are very effective antimalarials for the blood phase. Now, when she returned back, part of the protocol is that they get a peripheral blood smear to make sure there's no more malaria, and hers was negative, and it had been about 3 months since she had had malaria. But a couple of weeks after she was in New York, she started to have these fevers every 48 hours. So they were cyclical every other day. She had some chills, body aches, and headaches. She felt pretty sure this wasn't malaria because her prior episodes, she felt much worse. Okay. But, we did a peripheral blood smear. And again, you can see that inside the red cells, there are some forms that look like they're parasites. Sometimes it's a little hard to tell if a platelet is sitting on top of a red cell. That might be a bit confusing. But when you're seeing this chromatin dot and a ring form around it, that's the usual description you're going to see for Malarian babesia. This form actually is a schizont, and that's not usually seen with Plasmodium falciparum. You'll also notice that the infected cells are enlarged compared to the non-infected cells. Okay, and then some of them have these finger-like projections we call fimbriae. So all of those are clues for the lab to tell us that this is probably not falciparum. Okay, and it takes a lot of skill to really look at a peripheral blood smear and get a species of malaria because some of these findings can be subtle. But this happened to be a case of Plasmodium ovale, and Plasmodium ovale is interesting because Plasmodium ovale and Plasmodium vivax are two species of malaria that can cause a relapse. Okay, they leave behind a dormant form in the liver called the hypnozoite, so that even if you're treated for the blood phase of malaria, you can have a liver phase that reactivates weeks or even months later. And they require a special treatment that's active against that hypnozoite. Traditionally, we've been using primaquine. Tafenoquine is a relatively new antimalarial that works at the level of the liver as well. And these can be hard to distinguish between ovale and vivax. But I want to take us back to the life cycle of malaria so we can really think about how this all happens and how we can prevent it. So the first step in transmission of malaria most of the time is a mosquito bite. All right, so most of the time, someone's getting malaria because a mosquito named Anopheles has bitten them. And Anopheles is a mosquito prevalent throughout the tropics. And it's going to inject a form of the parasite that's called the sporozoite. So that sporozoite gets injected under the surface of the skin, and it finds its way into the blood vessels and eventually gets into the liver cells. So all species of malaria are going to spend some time in the liver. It goes on to replicate as a schizont, which is kind of like a bag of parasites that's dividing asexually. Patient is totally asymptomatic at this point. You get rupture out of the liver cell, out of the hepatocyte, and you've got hundreds of these little merozoites that go on to infect a red cell. So inside the red cell, this is the start of the phase where we're going to see some diagnostic features. So if we look at a peripheral blood smear, we might start to see these ring forms. They go on to mature as trophozoites. They divide as schizonts, again, in the erythrocyte, and eventually rupture out. And usually this is the point where patients start to have the fevers, the chills, sweats, headaches. You get a big cytokine release when you have rupture of the red cell and a lot of release of antigens. So each one of these merozoites, let's say there's 24 or 32 of them inside of this schizont, are going to go on to infect another red cell. And then exponentially, you can start to see very high levels of parasitemia. A few defenses against severe malaria. One of the important ones is the spleen. So if these cells are in circulation, they're shaped differently. So the spleen can kind of filter them out. And with vivax and ovale, that's a little bit easier because those schizonts are circulating. Now with falciparum, their schizonts are usually not circulating because they get adherent to the cell walls of the endothelial tissue. So they're kind of sequestered away in these tiny little capillaries, sometimes the capillaries to the brain, for example. And that allows them to replicate and keeps them from getting filtered out by the spleen. The problem is that if you have very high levels of these and a lot of schizonts in the brain circulation, for example, you start to see altered mental status, confusion, headache, and cerebral malaria, which has a very high mortality. So we want to catch these patients way before they get to very high levels of the parasite in their blood. So this cycle, the erythrocytic cycle is happening. There's also a sexual cycle of malaria where gametocytes are produced, and those go on to get picked up by another mosquito, and the transmission cycle continues with replication in the gut of the mosquito. But the gametocytes are actually helpful for us diagnostically because they look a little different depending on if it's Vivax orivale or malariae versus falciparum. Falciparum is the one that's got that classic banana shape or cigar shape. Okay, we see one of those on a board exam. We want to be thinking about falciparum. Just going back to that hypnozoite, remember Ovale and Vivax leave behind a dormant phase in the liver. Most of our antimalarials are acting at the level of the blood phase schizon. So we're treating here when we treat with atovaquone, proguanil, when we're using quinine, when we're using quinidine, the artesunates. All of them are really acting in the blood level. The primaquine or tafenoquine are the ones that act at the level of the liver to get rid of that hypnozoite and prevent recurrences. Another big board question will be related to the fact that when you give someone a drug like primaquine, you really need to know that they are not G6PD deficient. Okay, and the rationale is that primaquine is one of these drugs that can induce hemolytic anemia in people that have low levels of G6PD. Okay, so you're checking the G6PD level usually a couple of weeks after they've been treated for acute malaria, because there's a young red cells tend to have higher levels of G6PD, so you might miss them. But then if they're at a good level of G6PD, you're able to give them the primaquine to treat for the hypnozoite phase. The comment I wanted to make was that recently the WHO recommended a malaria vaccine, and that vaccine is really targeting this sporozoite phase. All right, most of the life cycle of malaria is spent intracellularly, either inside the liver cells or the red cells, but this is a moment when the mosquito injects these sporozoites when you can have an effective antibody response. So let's talk about treating malaria. It's divided between uncomplicated and complicated by the fact that some of those patients who come in may have a relatively mild form of malaria. They have no end organ damage, they have a low parasitemia, they have the ability to take oral medications. And that's many of the patients that you probably see who are what we call visiting friends and relatives category. So they're originally from, let's say, Nigeria, they're going back home, they're going to see friends and relatives. They've had malaria many times as a child, perhaps, and they may have some baseline immunity. So when they come in, they may not be as sick. However, in this case that I showed you with the renal failure, he was a returning traveler to Nigeria. His case had progressed a little further. The other thing to be thinking about is that as people spend more time away from malaria and recurrent infections, their immunity probably wanes as well. So if you have a milder case, we have options like Coartem, which is a combination of artemether and lumefantrine, FDA approved, within the last 10 years. And, it's widely used throughout the rest of the world and now available in the US, although less commonly seen in pharmacies compared to atovaquone, proguanil, or Malarone. So Malarone, we use for prevention of malaria, typically as a single dose of the tablet once per day for travelers who are going to endemic areas. For those that are coming back with malaria, the dose is 4 of those tablets daily for 3 days. And then there's some pediatric regimens that are here as well. Severe malaria before 2019 included a drug, intravenous quinidine. So, quinine has been the basis of a lot of our therapies against malaria for many decades. It was derived from a cinchona bark in Peru and then kind of chemically modified in different ways like mefloquine or primaquine. And IV quinine was really not produced in the United States, but IV quinidine was. It was mainly used as an antiarrhythmic, but it wasn't a very good antiarrhythmic. So the company that made it basically stopped production as of 2019. So in place of that, we now have access to intravenous artesunate. And that's excellent because it's really a better drug than IV quinidine that came with a lot of proarrhythmic activity and problems with induction of insulin production. So IV artesunates are excellent. It's just an access problem. So you'll see this on the CDC guidelines that if not in stock or available in 24 hours, you want to contact the CDC's malaria hotline. And that's probably a good idea anyway if you're dealing with malaria together with your ID team, to be in touch with the CDC, because often these complicated cases are very difficult to manage. So if you don't have it immediately available, you can certainly start with the oral medications like Coartem or Malarone. If you typically get that shipment within 8 hours, there's supposed to be stocks in pharmacies throughout New York City, but your local hospital may not have it immediately available. So you're making a lot of phone calls and calling the CDC as well as the pharmacy team. In the meantime, you can give some antimalarials by mouth. Combination therapy, a combination of something like artesunate with doxycycline and clindamycin and other older agents. So I wanted to talk a little bit about skin lesions in return travelers, because this is something that we have to think about a little differently once people have been abroad. And there's certain ones that are, just very high yield, I think. All right, so this first one is a creeping eruption. This is the beaches of Malaysia. So a 23-year-old woman who spent 2 weeks on the beaches of Malaysia, and she noticed a cat, on the sand. I had asked her, had you seen any animals like dogs or cats? And a week later, she developed this intense itching on her foot. The lesions moved from the sole of her foot over to the dorsum in about a day. And you can kind of see that there's a bit of a serpiginous track here, a little bit of a wandering, creeping eruption. Okay, so this problem is known as cutaneous larva migrans. Cutaneous larva migrans, or CLM, is one that we'll see mainly in the tropics. That's caused by a hookworm that is really not designed to get too far in humans. It's a dog or a cat hookworm. Ancylostoma brasiliensis is the name of this one. And typically, it's getting as far as the skin. It's able to wander around. There's an intense inflammatory response, so lots of itching, lots of eosinophils and IgE here. But it really doesn't make its way all the way into the blood vessels the way a human hookworm like Ancylostoma duodenale would. And the human hookworms have a life cycle where they pass through the lungs, they get to the GI tract, they cause a chronic anemia. But dog hookworms just cause this creeping eruption or cutaneous larva migrans. So if you do a biopsy, let's say the leading edge of where the inflammation is, there's a chance you're going to miss the worm because it may have already moved on and there's a little bit of a lag and then inflammatory reaction. So most of the time, you don't need that. You can just kind of recognize this clinically and treat with a single dose of ivermectin or 2 days of albendazole. Typically, this is also combined with some steroids as well because the symptoms of the itching are quite intense. Okay. Lesion on safari. So a 57-year-old woman who returned from a 10-day trip to South Africa and Zimbabwe with a skin lesion shown. In Zimbabwe, she had visited a game park, and in order to get to an outhouse, she walked through some shrubbery, some tall grass. Came back with this on the back of her knee. So on the Tuesday of her return, she felt decreased energy, and by Friday, she progressed to get fevers and chills. She was not taking antimalarial prophylaxis, and she denied any other skin lesions or rashes, didn't have any freshwater exposures. So if you look at this, this often starts as a bit of a papule and then becomes a necrotic tache noire. And this is another good type board image for ID. I don't know about internal medicine, but certainly for ID boards, they like to show pictures like this of necrotic skin lesions. So, there's several things that can do that. One would be anthrax exposure. If you get cutaneous anthrax from some spores in the soil, you can have a black eschar like this. If you've had a spider bite from a brown recluse spider, you can have one as well. It's also causing some skin necrosis, and it's typically very painful. But this problem is from a tick. The disease is called African tick bite fever, and it's caused by a rickettsial infection from Rickettsia africae. And it often presents with this typical eschar at the site of the tick bite that we call the tache noire, or the black spot. So there's different types of rickettsia throughout the world. Here in the US, you're probably going to mainly be seeing patients with rickettsia, which is the classic Rocky Mountain spotted fever. You might see rickettsial pox, here in New York, in Queens. Occasionally you get someone who's got a heavy exposure to mice or rats, and the little mites on those rats or mice can transmit another rickettsial infection. In Africa, the species that they mainly see is Rickettsia africae, mainly in the southern parts of Africa. This can present without a big disseminated rash that you might see with, let's say, Rocky Mountain spotted fever. might just be just that black spot, and then the systemic symptoms of fevers and chills and fatigue. Usually, this is a milder illness than what we see with Rocky Mountain spotted fever. It's important to recognize because you treat this with doxycycline, they get much better very quickly. You can do serology to confirm it, but that can take a couple of weeks, and you might have to wait for another 2-week illness, sort of period to get some IgG, and then maybe see a 4-fold increase in titer 4 to 6 weeks later. So, recognize that tache noire, use the doxycycline for a week, and they'll probably get better right away. Prevention's mainly through insect prevention measures. So again, DEET-based repellents, clothing that's treated with permethrin can also be helpful preventing this illness. This one is a 72-year-old hiker. So this is a 72-year-old woman who's very active. She'd been hiking in Peru several months prior to her admission. She came in with fever, confusion, unsteady gait, and her hiking included, this is Machu Picchu up in the highlands of Peru outside of Cusco. And then she also did a regular hike out in Harriman State Park with a hiking group. So she was there in upstate New York as well. So her lab values showed a very low white cell count. She's leukopenic to 1.3. She's got a hemoglobin of 13, platelets of 24, and elevated liver enzymes. So AST of 345, ALT 442, and a total bilirubin of 1.3. She gets worse and gets admitted to the NICU with worsening confusion and dyspnea. And again, I'm showing a peripheral blood smear here. And now we're not going to look in the red cells where, the red cells were pretty clean. I didn't see any actual intracellular organisms. But inside the white cells, we can actually find an intracellular organism or group of them that we call a morulae. Okay, so this morulae, when we look up close, is actually a little cluster of bacteria. These are technically gram negatives, although we usually don't, they don't retain the gram standard well enough to see them. And this is from a bacteria called anaplasmosis or Anaplasma phagocytophilum. So here in the Northeast, we typically see more anaplasma than Ehrlichia, but we can see both. This is a zoonotic intracellular bacteria that is originally, you'll see descriptions of this in veterinary textbooks among dogs, and now we see it very, very frequently among humans as we get more and more contact with the deer tick ixodes. So very difficult to culture. PCR is now available in many settings, so you can order an anaplasma PCR if you have someone with let's say a tick exposure. You can also do confirmation with serology. But again, if you recognize that kind of syndrome and start the doxycycline, that's the ideal therapy because then they usually get better quickly. So what is the syndrome? It's typically someone who's had an exposure to ticks. So Harriman State Park, lots of deer, plenty of anaplasmosis, babesiosis, and Lyme in these woods. In Peru, interesting, thinking about what's local endemic there, outside of Cusco, you really don't see much malaria because it's a pretty high elevation. So, about 1,500 meters, most of the time, you're not going to see Anopheles mosquitoes. So they do have a disease that's kind of interesting to think about called Carrion's disease, which is Bartonellosis from Bartonella bacilliformis. And that one, you could actually see some intracellular bacteria in the red cells, but usually that's a hemolytic process that doesn't affect so much the white cells and the platelets. But with anaplasma, you're definitely going to get some of that leukopenia. You're often going to see some elevated liver enzymes, and you're going to see some thrombocytopenia. So you get high liver enzymes with leukopenia and platelet counts that are depressed. Be thinking about anaplasmosis. This is rare that we actually catch it on the peripheral blood smear. Most of the time, you just suspect it, start the doxy, get some antibodies a couple weeks later, maybe have a PCR. But if you get a peripheral blood smear, once in a while, you'll actually see this little morulae. This patient did very well after treatment. I just wanted to show you the picture of the ixodes tick in its nymphal form. So this is what it looks like under the microscope. This is it in real life. You can see it's much smaller than the letters on our prescription pad and very easy to miss. So people that get these diseases like Lyme and Anaplasma and Babesia may not recall the tick bite. They may not have pulled anything off of them. And it's more about trying to ask about exposures. Have you been upstate New York? Have you been to Connecticut? Have you been to Long Island? Have you been to New England? To try to get at, whether they might have had some sort of a tick exposure. So the next case is skin lesions after returning from Costa Rica. So this was a 33-year-old healthy man who spent a week vacation in Costa Rica in early April. He did some river rafting. He was there in some kind of jungle huts that didn't really have sealed windows or air conditioning, just a little bit more exposed. And a week after his return, he noticed 3 skin lesions on his left wrist. And he thought they might be spider bites. Had a couple more on the flanks, 2 on the left, 2 on one on the right. And he was actually a veterinarian, so he was able to palpate proximal to his skin ulcers on the wrist, some nodules that he realized were lymph nodes that were enlarged. This is what the wrist lesions looked like. These ulcers that have a sort of depressed central area, they've got a raised erythematous surrounding area. And these are pretty painless, so despite looking very inflamed, fairly painless ulcers. And then on his flanks, he had some similar lesions. Some of them had little satellite lesions nearby. Okay. So looking at cutaneous ulcer, there's many things like the usual things we would think about here in the US, bacterial infections, maybe an MRSA infection. And, he was treated with topical antibiotics and Bactrim and didn't really get better. When you're seeing something like this, to try to get a diagnosis, there's a few things we can do. Obviously, if you got a good dermatologist, you could do a biopsy, try to get some cultures sent off to the CDC, and along with some pathology. But what we did was we took a little scraping, just with a 19-gauge needle, a little bit of the material from the center of the ulcer, put it on a slide and did what's called a diff quick, which is essentially a Giemsa stain. So what you get to see are the red cells. You're going to see some of the human phagocytic cells with their nucleus and cytoplasm. And inside of the cytoplasm of the phagocytic cells, you're seeing some parasitic cells. So they have their own nucleus and cytoplasm, and they have this barn-like structure here that's called a kinetoplast. The kinetoplast is actually very useful in distinguishing this from dimorphic molds like histoplasma, which can sometimes cause overlapping disease when they're systemic. So, just recognizing this is half the battle. We sent some of the material that we scraped and did a biopsy from to the CDC to confirm Leishmania. So Leishmania is an interesting parasite that's transmitted by very small insects called sandflies or Lutzomia. So there, sandflies, there are plenty of them all throughout the world. In Costa Rica, the species that they mainly have is Leishmania panamensis, which is what this patient ended up having. So Leishmania has a couple different forms. It's got a promasticate form that has a little tail or flagellum, and that is what's living inside the insect, inside of that sandfly. So when it takes a blood meal, it's going to inject some of the promastigotes into the skin, and instead of running away from phagocytic cells, they actually go, sort of use their flagella to get to the very cells that are often there to destroy invaders. So they're evolved to survive inside of these white blood cells that are in the tissues, macrophages, and they start to replicate. They transform from the promastigote to amastigote phase, and typically that's what we see diagnostically. So we're going to see them with their little nucleus and kinetoplast and cytoplasm, and as they divide and replicate, they rupture out of these cells. They start attracting attention of other immune cells, so we get an inflammatory response that you see in these cutaneous ulcers. Okay. Now, this is the cutaneous form of leishmaniasis. There are many other forms that I'll talk about in terms of mucosal disease. There's mucocutaneous leishmaniasis. There's visceral disease. But even when we talk about just cutaneous, there's very complex directions in terms of how we treat leishmania. So, if you have a case of this, you're probably, again, talking to the CDC. Our traditional antiparasitics included pentavalent antimony, which is it's a heavy metal. It's really not very well tolerated for a lot of people. There's a lot of cardiotoxicity. You have to come in for infusions, for every day for 20 to 28 days. So it can be very difficult to tolerate all that. Leishmania gets divided between Old World and New World disease based on the species that are around. Some of the species like Leishmania panamensis also have this ability to, after the skin lesion is healed, travel to the oropharynx and nose and cause a very destructive type process called mucocutaneous disease. So we want to try to avoid that. So, here's an example of a Bolivian farmer who had that mucocutaneous form of Leishmania brasiliensis in this case. And this clinical trial looked at the use of miltefosine, which at the time in 2007 wasn't FDA approved yet, but it's now available to us in the United States. And you can see that it was a very impressive result. This is 4 weeks of an oral medicine with a pretty minimal side effect profile, maybe some nausea, and really good results for many species of leishmaniasis. So it's certainly very encouraging. It is a teratogen, so it's something we have to use with caution in people of childbearing age. And it's hard to get access to in the United States. If you ever have a case, you're probably talking to infectious disease, and there's a company that distributes it here in the US where we go through some letters and we've been able to get some access to this medication for patients with leishmaniasis. Veterinarian, this was before it was FDA approved, so we were able to import it from Germany on an investigational new drug protocol. And he also had a very good response. This is 4 weeks of miltefosine, and about a month out, scars were becoming healed, and eventually a year later they were completely resolved, and he never had any mucocutaneous disease. Think about vector-borne tropical illnesses and their overlap with the immunocompromised world. So this is an example. This is a 53-year-old man from El Salvador with a history of heart transplant 2 months before his presentation with 2 weeks of lower extremity pain, swelling, and erythema. We saw him in the emergency room. He was febrile for 101.7, having fevers for about a week. Had erythema on this foot, and then had some proximal nodules as well. He had last visited El Salvador about 4 years prior to his admission, because his heart failure had been so bad. He had not been able to travel. It was kind of listed as idiopathic cardiomyopathy, and that turns out to be relevant to this case. So was not getting better on broad spectrum antibiotics. You can see there was an ulcer here. We had a biopsy done of this, and inside the sort of the border between the dermis and epidermis were again some parasitic cells. Now, when you're looking at these under low power, it's a little hard to distinguish, but again, we look at high power, we can see this bar-like structure called a kinetoplast, which is kind of distinctive for Leishmania trypanosomes. And the pathologist asked, has this patient had Leishmania exposure? And it's certainly there is Leishmania in El Salvador, but we realized that the heart failure was actually part of the story, and we had a PCR of the biopsy sent to the CDC and PCR of the blood, and those both confirmed a diagnosis of trypanosomiasis. So this sign is in one of my trips to Belize, and said, beware the chinch, Chagas disease, one bug, one bite, one life. And it's a picture of the vector here called the reduvid bug. The reduvid bugs transmit trypanosomiasis by taking a blood meal and adding insult to injury by defecating near the wound. You rub some of the parasite species into the wound where some of the insect species into the wound where the parasites are. And then you get sometimes an acute version of Chagas disease. So this trypanosome is mainly prevalent in parts of Central and South America. And it transformed from this sort of tripomastogote phase into the amastogote phase we might find in tissue. And again, this bar-like structure, kinetoplast, it's just a bunch of tightly coiled mitochondrial DNA, but it's, again, helpful to distinguish it from other things that look similar under the microscope. So these begin replicating inside of muscle cells, and in particular in the heart muscle cells. And that's where we see a lot of the chronic phases of Chagas. So this is acute Chagas. You might see Romagne sign, which is inoculation of some of the parasites into the eye with some swelling. It's got a much more concerning chronic syndrome where the heart becomes there's a dilated cardiomyopathy that results from the chronic inflammatory state. You can also see megasyndromes in the esophagus and the colon, but I would say that the heart is the main problem for most patients with Chagas. Now there's zoonotic infection here. You can see the triatomine bug feeding on a raccoon. Back and realized this was not idiopathic cardiomyopathy. This was Chagas disease that caused the heart failure. And now all of our patients with heart failure who are going for transplant, who are from endemic areas, are screened with serology for Chagas disease as well. So this is before treatment, after 8 weeks of benznidazole, which is an antiparasitic you can get from the CDC. He had excellent resolution of the ulcer. The swelling eventually went down, and there was no reinfection of the transplanted heart, which was the big concern when he presented. So reactivation Chagas disease, you're going to see sometimes in immunocompromised patients. And in that setting, benznidazole or nifurtimox can be very, very helpful. One more skin lesion case to talk about, and that's this one. It's a 29-year-old student, 29-year-old man who was not a sinus student. We had just gone to Belize with a group of students on a public health trip. But this person was not on our trip, but he had gone on some of the same places we had been. He had been snorkeling in the caves, but then he had gone to this ATM adventure trail. And when he came back, he had this lesion behind the knee. Okay, you can kind of get a better look at it here. It reminded me of something that I'd seen in Peru. I did a tropical medicine course in Lima, Cusco, and Iquitos called the Gorgas course. And the Gorgas course is a wonderful way to get immersed in all these tropical medicine cases if you're interested. The course usually runs over 2 months. Probably best timing is somewhere in the middle of your fellowship or late in your residency, but it's a great way to delve into these cases. So this was a 51-year-old woman who had a tender erythematous expanding lesion on her arm. 3 days prior to onset, she had returned from a 2-week stay in the jungle region of Pucallpa, which is in the Amazon basin of Peru. And you can see that this lesion, kind of has some erythema to it, but it also has a central black spot. You might think that's another tache noire or necrotic lesion, but that's actually a breathing hole. And what's just under the surface of this, when you put some Vaseline or other occlusive type of material, is you're going to occlude the breathing hole, and out is going to come a larva of the botfly. This is myiasis from Dermatobium hominis. So this particular fly is very interesting. So this is the case in Peru. The one that was from Belize, which is another place where you can see a lot of this. This never completely emerged, so we had to do an excisional biopsy to get this little larva out. But the larva is going to be the larva of this rather large black fly that catches a mosquito in flight. The mosquito gets sort of a lot of these eggs on its gut, and then when the mosquito takes a blood meal, it's actually going to transport the eggs to let's say another mammal. So the eggs burrow under the skin, and you get these larvae that start to grow, eventually replicate, and then normally they kind of drop out of the animal and then pupate in the soil and become another fly. Humans once in a while get bitten by these same mosquitoes, and they can get this black fly larva under the skin. And it's really just about recognition to say, okay, this is what it is, just to do some occlusive therapy, and it's going to usually come out. If not, we do the excisional biopsy, and this is what it looks like on our cross section. You can see there's a big inflammatory response around this larvae. Generally, there's no long-term sequelae or consequences of this, but it's just about recognizing what this is. Preventing all these insect-borne illnesses, there's several strategies. We have impregnated bed nests that are going to be treated with things like permethrin. This can be used on clothing as well. It's just one brand, but the idea is to deep base repellents ideally have at least 33% to last you like 12 hours of protection against mosquitoes that transmit malaria, dengue, etc. And my last comments on travel are just about traveler's diarrhea, since that's a common problem people deal with. I would say for most people, if it's mild, you don't need an antibiotic, maybe some bismuth, like Pepto-Bismol, maybe some Imodium, like antimotility agents. But for some people, as soon as it starts, they want to go right to the antibiotic, and that's actually probably okay. For many busy itineraries, you're not going to lose, a whole day of safari or other travel to traveler's diarrhea. So I think it's actually fine to go right to a macrolide. So macrolides are nice because azithromycin, you get a long half-life, so single dose therapy often is all you need. Quinolones are fine for many places, but quinolones, we have some resistance to deal with in Campylobacter, especially parts of Southeast Asia. And it's usually a twice-a-day therapy, and the quinolones have a little more side effects and photosensitivity and things like that to think about. And hydration is a big key for this, because a lot of traveler's diarrhea is from enterotoxigenic E. coli that can really produce this very secretory diarrhea, and people get dehydrated fairly quickly. So good to just remind them about that. So I think the big points I wanted to just tell you about today were that numerous recent outbreaks have demonstrated the speed at which zoonotic infections can be transmitted globally. Vector-borne illness remain a major public health problem throughout the world, and understanding the biology of the vectors can be as vital as understanding the biology of the pathogens themselves for designing new interventions. So let me stop there and see if we have questions.
You guys know that you can unmute yourselves or you can text in the chat if you have any questions. I read that Sophia is asking, let me just open this. Can Chagas-related cardiomyopathy be reversed once the infectious etiology is treated?
Excellent question, Sophia. It's unfortunately not been very successful. So once you get to this stage of cardiomyopathy, very hard to get much reversal with benznidazole or with nifurtimox. And there have been some clinical trials looking at that problem, and unfortunately, they didn't have a lot of success. So a lot of this is about prevention, so prevention of the insect bites, prevention of transmission of Chagas through other means. It can be transmitted through the blood supply. So blood transfusions in many parts of the world, including the US, are now screened for Trypanosoma cruzi through PCR. Pregnant women can transmit from mother to child. So, in endemic countries, looking for this can be also helpful for prevention to children, especially. So in the early phase, the acute Chagas, that's more amenable to treatment than later. Once you get to the later stages, there's actually not that many parasites in the myocardial tissue. So once you start looking for it, like we actually looked in the explanted heart of the patient that went through the transplant and reactivated. And even though we found abundant parasites reactivating here in the skin, not many in explanted heart. It's more just in lymphocytic infiltration. There might be a few nests of these over the years, but it's just that chronic inflammatory response. So yeah, and unfortunately, we don't have a good therapeutic drug for the chronic Chagas cardiomyopathy. That's a good question.
I have a question. Thank you so much. That was great. I had a question about the Chagas-related cardiomyopathy as well. The need to screen before a cardiac transplant, is that because of risk of reactivation with immunosuppression, or what exactly is the point?
Yeah, exactly that. So even though we think about Chagas mainly in places like the heart and the esophagus or the colon, it does widely disseminate. And when we do start giving tacrolimus and MMF and steroids for the transplant anti-rejection regimen, that's when you see a lot of this reactivation in the skin or other parts of the body. So a lot of the literature for this comes from Argentina and Brazil, where in the past that was one of their major indications for heart transplant was Chagas cardiomyopathy. Seen a big reduction in that through things like screening the blood supply. But they've got a good literature on what to do when you do transplant someone with Chagas and about it. The frequency of checking PCRs, doing some post-transplant prophylaxis with benznidazole. Nifurtimox tends to have a little bit more in the way of interactions with tacrolimus and MMF. So, most of the time benznidazole would be the go-to. But that's the idea. So if you know about it ahead of time, you're more likely to prevent the reactivation either through the screening or, with serial PCRs or with prophylaxis.
Thank you so much.
Mm-hmm. Yeah, great question.
I also wanted to thank you, Dr. Caplivski, for such a great lecture. I actually come from an area where, we have a high burden of disease because of flaviviruses. And coming to the US, I found that that's less common. There, we basically, like we do for other parasitic infections and whatnot, we base our suspicion on our clinical exam, the history taking. And of course, for viruses, we mostly treat symptomatically. I noticed that here we do tend to do serologic testing as the CDC recommends. What would your advice be when you have cases where you have people that have traveled or originally from places where flaviviruses circulate, let's say dengue, yellow fever, even Zika, what would your advice be when you suspect there might be some cross-reactivity in those serologic tests?
That's a great question. And it certainly came to light, especially during the Zika outbreak in 2015 to 2016 in the Americas. So, the flaviviruses look a lot alike to our immune system. Yellow fever is your classic one. So many people that have been vaccinated against yellow fever may have some false positive reactions to an IgG of Zika, for example. Or if you've had dengue before, you could have a false positive dengue. And if you remember back when Zika became a big problem in the Americas, we were relying on sort of a stepwise testing. There was serology initially for someone who had a suspected case or exposure. And it was a long delay because if you had a positive Zika antibody, the sample would be sent to New York State lab for a more labor-intensive test called the plaque reduction neutralization test, or PRNT. And the idea was that you could see some cross-reactivity with dengue, but if the number of plaques on a plate of a viral tissue culture was reduced significantly by antibodies from the patient, and they were specific to Zika, you had a higher suspicion that was in fact Zika versus dengue. There are some PCRs that are available. They have some limitations too, but I would say that as you say, the clinical suspicion becomes very important. There's so much clinical overlap, among chikungunya, Zika, and dengue. But in cases of pregnancy, that's probably, or couples, deciding to conceive, that's probably the highest stakes scenario. Is could they have Zika versus dengue? So I think at this point, the Zika outbreak, fortunately, we've seen a great reduction in the number of cases compared to 2015, 2016, and dengue has kind of come back and taken over in most of the areas where Zika was endemic and really causing a big outbreak in the Americas. So more likely you're going to see more dengue at this point in most of the the Caribbean and South America, but certainly Zika is still out there and still something we have to think about in certain travelers.
Thank you for your answer. I just read in the chat there was another question, I'm assuming related to the prior discussion about Chagas. Any other screening tests before immunosuppression? Strongyloides, Chagas, anything else? Fatma is asking.
Yeah, Fatma, thanks for bringing that up. I think the strongyloides is probably the best thing for you to remember from this whole lecture, and I didn't even talk about it, so I should let you know that that's probably the most important. If you're dealing with immunocompromised patients, always try to get a serology for strongy because it's one that can really sneak up on us, and it's much more common than we think about. And it's the one that can be a lifesaver if you really realize that person has had it before you give them their steroids or their heart transplant or their kidney transplant. And especially now with all the use of steroids we're doing with COVID, it's certainly important to be thinking about that. And I think when we go through these big peaks of COVID, sometimes you don't even wait for the serology to come back. If you have someone from an endemic area and you're hitting with all the dexamethasone, feel free to use some ivermectin, at the same time, and not for COVID, but just for the strongyloides possibility, because that hyperinfection syndrome can be very, very subtle at first, but then very, very scary when it gets to later stages. So yeah, I would say that's in terms of these tropical infections, heart transplants, we think about Chagas. For strongy, pretty much any transplant if people are from endemic areas, and then some of the more typical things you'll see checked are things like CMV and Epstein-Barr viruses, because some of those can also reactivate.
I just wanted to thank Dr. Caplivski. I always call him Daniels.
No, that's fine.
He's one, just so you can see why he's got so many teaching awards from the medical students and also from the residents. So I'm grateful that you were able to take time in and teach as well. And you were the first person I thought about when I was brought up about this topic. So thank you for this lecture. It was really great. Thank you. And I was listening.
Yeah, so fun
I
to
just
see
had
you,
the video down.
Yeah, great.
That was amazing.
I wish we could be there in person, but maybe next year, who knows?
Yes, maybe next year. Yes, thank you. And yeah, I agree with the Gorgas. I know we've had one of our residents didn't get to do the Gorga, but did in Minnesota. But we were trying to get him to be able to do the Gorgas course. But that is something we've tried to do for the residency, but definitely if you're interested in fellowship, it's definitely a great course for everybody. Thank you.
Everybody.
I agree with Dr. Sora. That was an amazing lecture. Thank you so much again for coming today.
My pleasure.